Hi, I'm Andrea Ivory, your host of Living for Longevity, a podcast designed to help you live your best life, presented by the Women's Breast and Heart Initiative, a nonprofit organization that transforms and saves lives through disease prevention and early detection. Today, I am honored to introduce our distinguished guest, Dr. Lauren Carcas, a board-certified medical oncologist that specializes in breast cancer detection, diagnosis, and treatment at the Baptist Health Cancer Care. Dr. Carcas is also a distinguished researcher, published researcher, who serves on the medical advisory board of the Women's Breast and Heart Initiative, and also participates in many professional and community endeavors. Dr. Carcas, thank you so much for taking time from your busy schedule to join us today.
Thank you for having me.
And welcome.
Thank you. I appreciate you inviting me. This is something that I always enjoy doing, educating people about what we do and what our role is in healthcare.
Thank you so much. Well, all women are at risk for breast cancer. The mere fact that we have been blessed, endowed with breasts, puts us at risk for the disease. And, it's really common because 1 in 8 women will be diagnosed with breast cancer over their lifetime. And it is the most common cancer diagnosed in women in the United States and worldwide. And breast cancer, unfortunately, is being diagnosed in younger women at earlier ages with more aggressive breast cancers. Mm-hmm. And today, I am so honored that we are going to delve into some breast cancer basics and talk about early detection. So, Dr. Carcas, are you ready?
I'm ready.
Let's get to it.
Okay.
Let's get to it. So first, please, tell us more about yourself.
Okay. So, as you already said, Lauren Carcas, I am a medical oncologist, and I treat breast and gynecologic malignancies with Baptist Health Cancer Care. A medical oncologist is a person who follows patients from the time of their diagnosis and oftentimes even before their diagnosis, during a high-risk screening period, to a diagnosis, through treatment, and often all the way through survivorship. I love being an oncologist for many reasons. What drew me to oncology is the science of oncology is fascinating, and it is ever changing, and we are learning so much more. Perhaps not that we can currently cure everybody, but we know how to help them live longer with an excellent quality of life, and that is paramount with what we do. But most importantly is I get to have a beautiful relationship with my patients. My patients know about my family. They know my children by name. I know my patients' most dear fears and their biggest sources of joy. I know their long-term goals. I'm there through all of that. And that is such a fulfilling place to be, that not only are they my patients, but they become my family. I often feel like I'm a mother hen and I tuck all of these little patients under my wings to take care of them, but it's my joy to do so.
That's amazing. We need more medical specialists that care so deeply. So thank you for that. And please tell us what a medical oncologist in your specialty does. What exactly do you do on a day-to-day basis?
So on a day-to-day basis, I see patients. I have a portion of my clinic that is high risk. So I might have patients that have a gene predisposition, or if not a gene predisposition to developing breast or gynecologic cancers, they might have a strong family history of cancer or breast cancer at a young age or even later ages. And we know that those women need to be followed a little bit differently. So I help organize their screening and I will see those patients every 6 months. But the bulk of what the medical oncologist does is we see patients after they have been diagnosed with breast cancer. When they are diagnosed with breast cancer, they will have a whole team of care. They will have a breast surgeon, a breast radiologist, a medical oncologist, a radiation oncologist, and then all of the ancillary services of nutrition, psychology, psychiatry, acupuncture, massage, everything else that comes along with treating the whole patient. But the medical oncologist is the one physician that will follow the patient for the duration, from their diagnosis for at least 5 years up to 10 years, and oftentimes for the entire life of the patient. We're most well known for what scares patients the most, which is chemotherapy. We are the ones who prescribe chemotherapy. We make those recommendations based off of the type of tumor, the stage of tumor, the patient's risk. We also make recommendations for patients based off of whether or not something we can give them can reduce their risk of cancer recurrence. And some patients, that might just be a hormone blocker to reduce their risk, and they don't need chemotherapy.
What are the different types? When we think of breast cancer, we think of one disease.
Right.
Many people don't understand.
It's not.
It is not one disease. So would you be so kind as to share the different types of breast cancer?
Yes, so this is a big ask, and I'm going to do my best to explain. So most people believe that breast cancer is just that, breast cancer. And I will have patients come in to me and they say, oh, but my neighbor had breast cancer too, and this is what they did. But it doesn't matter. Just like some people take Tylenol for a headache, some people take ibuprofen for a headache, some people take aspirin for a headache, our bodies respond differently. So what works for one might not work for the other. But even more importantly, in the world of breast cancer, we often classify breast cancer by the type of breast cancer that there is. If you think of a diagnosis of breast cancer, you have two main branches. You have your ductal carcinomas, that's the cancer of the milk ducts that bring milk to the nipple. And then you have lobular carcinoma. Those are the milk lobes where the milk is made. And then it flows through the duct to come out the nipple. If you develop a cancer of a duct, we call that a ductal carcinoma. That is overwhelmingly the most common type of breast cancer. If you develop a cancer of a lobe, we call that a lobular carcinoma. But those are only the first two major classifications. When somebody's really saying what type of breast cancer they have, what we want to know is what is on the surface of their tumor cells. And the reason this is such an important ask is what lies on the surface of a tumor cell is a targetable therapeutic option for treatment. If that tumor cell has a little mouth that eats estrogen and progesterone, that means that those tumor cells are being fed by hormone that it finds in the person's body. So one of the treatment options is to block that mouth. So then you can starve out tumor. That would be a hormone receptor positive breast cancer. That's an estrogen receptor and a progesterone receptor. Sometimes you can have estrogen positive, progesterone negative. You can have both positive. You can also have both negative. The next thing that we want to know is, does the tumor cell harbor something called a HER2 protein? The HER2 protein is an oncoprotein. It's a cancer-causing protein that kind of sits right on the top of the tumor cell. And the reason this is so important is it is a high-risk feature. It means that the tumor's going to be more aggressive. But fortunate for us, we have targeted antibody therapy that can actually be given that targets the HER2. So the presence of the HER2 is important for treatment choices. So that would be hormone positive, estrogen, progesterone, HER2 positive if you have the HER2 protein. Now, a tumor that has none of those, we call a triple negative. And triple negative, by current standards, is the most aggressive breast cancer because it does not have a clear target to target with therapy.
It is very complex, and I thank you for breaking it down somewhat to a layman's terms. And sadly, in the United States, it is estimated that more than 43,000 women will die as a result of breast cancer. And it affects everyone because these are our grandmothers, they're our mothers, they're our daughters, our sisters, our family members and friends. But there is hope because research has proven that when breast cancer is detected early, that there's up to a 99% survival rate. And in other words, early detection saves lives.
Absolutely.
It does save lives.
Absolutely.
And there are screening guidelines, recommendations that women follow for the early detection of breast cancer. And over the years, they've changed. Mm-hmm. And they have even confused women even
Absolutely.
more. So please, Dr. Carcas, if you will, share the early detection recommendations for breast cancer for women who are at average risk.
Okay. So you're right. It is very confusing because we have the USPSTF, which is the
The United States Preventative Task Force Services. Yeah.
Right. So they come up with guidelines for screening. Mm-hmm. So that's one organization. Then you have the American Cancer Society. And then you have multiple others. And unfortunately, none of them are consistent. And they have gone back and forth, back and forth. Mm-hmm. But all medical organizations, gynecologic societies, surgical societies, oncologic societies have never wavered. The recommendation for an average risk woman, meaning not a strong family history, not a personal history, is to begin mammogram screening at age 40 and to do it annually. If a woman is found to have dense breast on their mammogram, it might recommend to add an ultrasound to their routine screening annually. And that's the guideline.
We just said it. And we know it's true. Early detection saves lives. Can you just share what that means? How does early detection save lives?
So we know that prognosis, the likelihood that a woman or a man, for that matter, will survive a diagnosis of cancer is very closely tied to how advanced the stage of disease is at diagnosis. If a woman is getting her mammogram on an annual basis, we are more likely to find a problem when it is a minuscule problem. There is less likelihood for need for surgery, there's always a need for surgery. There's less likelihood for a need for chemotherapy. When a patient has higher risk, higher burden of disease, they are more likely to need chemotherapy, bigger surgeries, because when it's just in the breast, it's much easier to treat. If it has spread to the lymph nodes, which I think of like a gatekeeper, I often tell my patients, if a tumor's in the breast, those tumor cells will travel on the on-ramp to get to the toll booth. Your lymph nodes behave like a toll booth. They're going to collect as much as they can to protect the highway. Once tumor has gotten onto the highway, it is no longer curable. The goal of early detection is to find it in the breast.
When it's localized.
When it's localized, because then your therapy is more likely to be localized. That's not to say that women who have stage 1 breast cancer don't need chemotherapy. There absolutely are women with stage 1 breast cancer who still need more aggressive treatments, but that's based off of that type of cancer that they have, that we can make that decision. But their long-term survival is very much related to whether or not disease has spread to stage 2, stage 3, or to their body.
And I truly believe that as a breast cancer survivor who was diagnosed at its earliest stage, you have choices. That is the beauty of early detection. You can make a decision on whether you want to do something a little bit more prophylactically, like remove your breast, or, once it becomes, okay, stage 1 or more, there are tougher conversations that have to be had. So can you tell me, and not, can you tell our audience what the difference is between a screening mammogram and a diagnostic mammogram? Because we already always say, and I'm going to say it a little bit later, get your mammograms. So there is a difference. Would you share what that difference is?
So for the average risk woman who does not feel anything in their breast, a screening mammogram is what's indicated. A screening mammogram basically means it's the basic imaging angles looking at the breast to make sure that there is nothing seen that is abnormal. That also means that the radiologist does not need to be on site at the time of the mammogram. The images will be sent to the radiologist to be read, and a report will be sent to the patient's doctor. A diagnostic mammogram is indicated for any woman who feels something in her breast, who recently had a biopsy, and this might be a follow-up of something that was seen 6 months ago, because the radiologist is then on site to see, do we need more angles? Is there more that needs to be done before this patient leaves so that we can make sure that what we're dealing with is a benign process, or if more is needed, we can do it at that time.
Excellent. We talked a little bit about higher risk. Mm-hmm. What puts women at higher risk? Can you speak to that, please?
So I'm very passionate actually about this because I think that we really need to talk about breast cancer. Patients, and we often see it's cultural too, that people do not talk about a cancer diagnosis in their family. And the only way that you can be empowered to know your risk is to understand what has happened in the generations that predate you. So what makes a woman high risk is a strong family history of breast, ovarian, uterine, colon, prostate cancers. So if you have a strong family history and all of your uncles had prostate cancer and you're the first girl in a long line of a bunch of men, prostate cancer should make us more concerned about your risk as a woman for breast cancer. It's family history. There's also genetics. I believe that genetic testing is still underutilized. When you have a strong family history of malignancy, you can discuss the process of genetic testing with your gynecologist or even your primary care physician so that then you can know whether or not you harbor a gene mutation. The most commonly known gene mutation is the BRCA gene. BRCA1 and BRCA2, this is what Angelina Jolie has and why she underwent prophylactic mastectomies and removed her ovaries and tubes to reduce her risk of developing cancer. Because if you have one of those gene mutations, you are at an inherently higher risk of developing breast cancer. The average woman's risk for developing breast cancer is about 12 to 13% over the course of her lifetime. If you have a BRCA mutation, it's anywhere from 60 to 80% over the course of their lifetime. That means that we need to screen differently and more aggressively.
Wow. I didn't know it was that high. I'm so glad we're having this conversation. I didn't know that having the BRCA gene placed you so much more at risk. So I hope that our audience is listening intently.
It does. So it very much depends, right? The risk might be as low to 40 to 60%, but it's family history. If you have a gene mutation and every woman in your family has had breast cancer by age 40, your risk is higher, on the higher spectrum of that 60 to 80%. Right? Because it's telling us, the word is actually called penetrance. That means I have the gene. What is the likelihood of the gene doing what it can do? How penetrant is the gene? There are certain families that are highly penetrant for breast cancer. There are other families that are highly penetrant for ovarian cancer and not breast cancer. That's what it's telling us. Yes, you have the gene, but how is it going to behave?
So besides screening, this is a lot. Besides screening, what other strategies can you share with the audience to help them reduce their risks? for breast cancer?
So for the average risk woman, really for all of us, even if you have a gene predisposition, living a healthy lifestyle is super important. We know that exercise, we usually say 150 minutes of moderately vigorous cardiovascular activity per week is super helpful. It reduces the risk by about 20%.
That's a lot.
It is. 20% of 13%.
Right.
Okay. Not 13 minus 20%.
Right.
Okay. So it's small. You're knocking off a couple percentage points, but if you keep doing that, you're moving in the right direction. Food, making sure that you eat whole foods, right? Like what we have here, right? Eating whole foods, trying to minimize your processed foods, trying to minimize your simple carbohydrates. Those are all beneficial. Alcohol increases risk. It is said that more than 3 alcoholic beverages per week increases the risk rather significantly. And that's very important because it's a serving, not a bottle. And I have that conversation often because people don't really think in terms of servings. But it's choosing a healthy lifestyle, staying away from smoking. But really, we can control what we put into our bodies and what we do with our bodies, but we can't change our genetics. So communication is the other thing we must do.
This has been an extremely insightful conversation. And, as part of our organization, we want the community to know that the Women's Breast and Heart Initiative breaks down barriers and mobilizes people and resources to give low-income individuals a fighting chance against breast cancer and heart disease. And we have amazing partnerships. I am so honored that Baptist Health is our partner in prevention and many other things. And if you live in Miami-Dade, Broward, or Palm Beach counties, and you do not have access to early detection strategies, please contact the Women's Breast and Heart Initiative for no-cost and low-cost options. Additionally, in the month of June, we celebrate our Summer Breast Cancer Awareness Campaign. In October, we paint the town pink. Everybody's talking about breast cancer. And then by the end of October, everybody's over it and they don't want to hear about breast cancer. So we've taken the opportunity of commandeering June, specifically celebrating National Pink Day. And on June 22nd, we will celebrate National Pink Day. And the most important thing that we can do is provide access to that screening. So we've partnered with Macy's at Westland Mall, and we'll be bringing the mobile mammography units down and providing no-cost mammograms, whether you're uninsured, underinsured. We want to address the social determinants of health. And when you come that day, not just get mammogram, not just get heart screenings, but Macy's is our partner. We'll be giving mini makeovers for everyone who completes their screenings. We will also, Macy's is also going to give everyone a gift card, a Macy's gift card for just being proactive about your health. We also will have food samplings there. There will be so many other things. Starbucks is raffling off a Starbucks basket, and we'll have fragrance baskets that will be raffled off because we want to make it fun. We want to make sure that people come out and get screened and they have a great time. But all of these services on June 22nd are by appointment only. So we ask our listening audience to please contact us at 305-825-4081 to make your appointment and take advantage of all of these wonderful things. And I always like to close with gratitude. I am so grateful first to a high school student, Maritza Costa. He is an amazing young man who has his own nonprofit, which literally teaches the next generation about civic engagement and how to lead our country. He's doing amazing things here locally, across the state, and even in Washington, D.C. Remember his name. And then also to the town of Miami Lakes Mayor, Manny Sid. Thank you so very much for opening your heart and your office and the podcast studio in your office to host Living for Longevity, and to our amazing guests, our very distinguished Dr. Lauren Carcas. Thank you so very much for what you do for not only your patients, but the community. Thank you for doing what you do for our organization. And I'm going to ask you to please keep saving lives.
Thank you.
Keep doing research, because you're going to be finding things in the future. And keep serving, keep loving your family, and keep living your best life.
Thank you.
Thank you for being here. I am your host, Andrea Ivory. Please tune in next month for another episode of Living for Longevity, a podcast designed to help you live your best life, presented by the Women's Breast and Heart Initiative. Featured will be stories of triumph over tragedy. We're going to have lifestyle experts, strategies to help you live a disease-deterrent lifestyle, and resources to guide you along the way so that you can live your best life and enjoy more time with family and friends doing the things that you love to do. Please subscribe to the Living for Longevity podcast. We're also social. You can find us on Facebook and YouTube at the WBHI, and on Instagram and X at WBHI. Well, please join us next month. We look forward to seeing you. Until we meet again, live your best life.